the change and move. So I had to click it 3 or 4 times.
Please put your name and practice in the chat.
Perfect. Thank you for that. So the chat is how you're going to prove your attendance here tonight. So please type your name in there, name and practice, as pointed out. And then I'm going to go ahead and get rolling as folks filter in and enter their name into the chat. So again, I want to thank Diego Conhidalgo for everything that you're going to see and experience tonight. If you suddenly halfway through think this is the worst session I've ever heard in my life, you can blame Diego for it. So good news can go to me, bad to Diego. Before we get rolling with our sessions tonight, I want to turn it over for a moment to Bob Adams, who is the AHP Director of Pharmacy Services, who just wants to provide a quick update on opportunities for pharmacy engagement. So Bob, take it away.
Thanks, Chad. Hi, my name is Bob Adams. I'm the Director of Pharmacy Services for AHP, and it's a pleasure meeting with you tonight, and I look forward to meeting with you in the future. Over the next few months, I would like to visit your practices, meet with your teams, and hear what your pharmacy needs are, and look for opportunities to better serve you and your patients, as well as talk about some of the pharmacy services that we offer across the system. Things like specialty pharmacy, retail pharmacy with compliance packaging, mail order, home infusion, dietary supplements. So I'd like to meet with you, listen to your teams, see what your needs are, look for opportunities to better serve you in your practices, as well as your patients at home. If you're interested in hearing more or meeting up, the contact information is on the slide, and it'll be shared again with you at the end of the night. Thank you and have a good night. Back to you, Chad.
Thank you very much. It's almost like we're running our own news segment now. So the purpose of tonight is, as we talk through this at our PCP advisory, was really to focus on some of the commonly encountered dilemmas in clinical practice for primary care, and get some of the subspecialty experts to comment on, present the best level of evidence, and then give us some guidance on what the appropriate testing in the primary care setting would be. And then when is the appropriate time to phone a friend and refer to subspecialty, both to triage those referrals most appropriately, but also to identify the segment of the population who may need that more subspecialty care. So our first presenter tonight is Dr. Mark Levstick. Dr. Levstick is the interim chair or interim chief of the gastroenterology and hepatology division at URMC. He's a professor of clinical medicine and a specialist in fibrotic liver disease. So Dr. Levstick is going to be presenting on liver disease testing and referral best practices. So I will turn it over to Mark.
Appreciate that. And I really have tried to be as brief with my slides and commentary as I can. And I really want to have this as much as an open forum, because a lot of this really is discussion. And I know when Diego contacted me, he said, we just want to get bare bones, how to get in touch with you, how to get through the system, and really who do we need to refer. So I'm going to try to screen share, and this better work. That work that time?
Yes. Good.
So you can see it?
Yep, perfect.
Okay. So, the bottom line is, it's not working for me though. I'm going to have to unshare. 1 second. I apologize. Yeah, I'm just not getting the full view. I'm going to ask Renee if she doesn't mind sharing and advancing for me, because I'm obviously technologically challenged. I have teenagers and people for this usually. But the bottom line is, I've been here about 6 years, and I have to really commend the University Department of Medicine, Highland, Strong, everybody, in really trying to move the GI program and liver program forward. Can you get it up and moving, Renee? Can everybody see it?
No.
It's coming.
Okay.
There you go.
So we just go to the first slide, please, Renee. Again, I'm trying to have as much of a dialogue. And what I really want to just sit there and say is, what are the common things that we see? What are you going to see in clinic? Understand that you really are the backbone of doing case finding for us and understanding that, as we've talked about, our infrastructure is such that I think we have to try to be as efficient and utilize things as much as possible. Let you know that when it comes to GI, there's hepatologists, but we have an array of hep APPs, urgent clinics. We work in a multidisciplinary place with transplant surgeons. Liver tumors, liver masses, there are many ways of getting your questions answered, your patients seen. I really don't want to spend much on liver transplant because that's not what we're here. We're really here about primary care liver and really help get your patients in. So next slide, please. So you always start the case, and this is not my accountant, but this is usually something that you guys will send me. Somebody who lifelong has had normal labs, but suddenly has a jump in their alkaline phosphatase. Diabetic for 25 years, kind of our standard dad bod sort of person on a little bit of metformin, a little bit of blood pressure, and just saying, I'm kind of tired. I've got a little bit of sleep apnea, that's not new. BMI is 33, and this is the sort of patient that you would see in clinic. And I get sent this saying, hey, alk phos is up, what's going on? Next slide, please. And the transaminases really are not that abnormal. And we know that in probably about 60–70% of our liver patients, they're not. But you can see by the platelet count being low, there's likely portal hypertension. We measure the creatinine, the hemoglobin A1C, all saying things aren't quite normal. But the workup essentially is normal. So you get somebody with an isolated alkaline phosphatase. So what's the first thing you do? You do the normal liver workup, which are the transaminases. You look for autoimmune liver disease, kind of the common things. So I'll go through this in a little bit. Get sent to me, and we do a fiber scan, and I'll spend a bit more on that later. But next steps with this, anyone wants to volunteer, that's fine. If you want me to just keep going, that's what happens. They get an ultrasound done, and they find you got a 2.4 centimeter mass. Patient's really asymptomatic. We do the follow-up CT with that, and there's arterial enhancement, portal venous washout. And if I hear those two words, I know this person has a liver cancer. And we see a fair bit of this in our fatty liver patients. It's becoming much more prevalent as metabolic syndrome grows. We have a tumor board here, which is, as my wife calls it, a nerdathon. So you've got transplant surgeons, transplant hepatologists, medical oncologists, and radiologists. And every Thursday we go through food, films, images, etc. As a service to you, even patients we don't see, just to give you guys a reading. This person had NASH cirrhosis based on history, got a radiofrequency ablation, then went on to transplant evaluation because we know they're oncogenic. Next slide. So what are the common things that we see? Number one cause of liver disease in Rochester is fatty liver. It counts, if you do ultrasounds, 38% of people will have fatty liver on ultrasound. I'm sure you've all seen that. So what do you do with them? Well, we'll get to that. Alcohol related used to be 11%. In the time of COVID, it's 41% of patients now with acute alcoholic hepatitis, or folks who, have a long alcohol history and are just doing more, sitting in the garage, watching movies all day. That's what some of my patients drinking White Claw. I don't know how anybody would do that, but come here with acute on chronic liver disease. Autoimmune hepatitis, and these are usually kind of two groups, the younger folks with ulcerative colitis and sclerosing cholangitis. Autoimmune are just more folks in their 40s, 50s, 60s who have mild waxing waning transaminase elevations without real findings. Metabolic syndrome, we see folks with above ideal body weight, big thick necks, sleep apnea, right heart failure, and have congestive hepatopathy. And you'll see that on an ultrasound with a big dilated IVC, ASTs usually up to 300, 400, 500 range. Hepatitis B and hepatitis C, other than in folks coming into the areas, become far less prevalent. I did a lot of work on hemochromatosis, so I just want to be clear. Every patient who has an elevated ferritin thinks they have hemochromatosis. 99% of them have alcohol toxicity with it. And we'll give you ALTs, we'll give you a ferritin of 500–600. If you do not have C282Y homozygous status, they will not get liver disease from that as an isolated thing. So I just want to make sure that's clear. So patients will tell you, everyone in my family has hemochromatosis. They don't. Methotrexate patients, folks on amiodarone, you'll see them with liver disease. But the one thing I wanted to say is the advent of statins, cholesterol-lowering agents, Tylenol use is almost universally safe. The number one drug we use in our cirrhotics on the transplant list is Tylenol. 3 grams a day, you're not going to get into trouble. If you're combining it with a pint of Johnny Walker, you might get into trouble in that. But again, it's got to be chronic alcohol use. The risk of statin-related liver disease of a significant nature is 1 in 640,000. So in general, start them on the statins, whatever you do. And if there's ALT and AST is less than 3 times their beginning, don't worry about it. And I just want to make sure that was clear. The other things, alpha-1 antitrypsin, all these other things, we just don't see it very often. And if they do, they're usually a little bit sicker. You should not be picking those folks up in your primary care clinic. Any question on any of this? Last thing I want to do is listen to myself. Okay, we'll move on. So what do I expect you folks to be doing in your clinic? You know, as part of your normal CMP, you're going to, you know, liver irritation numbers are ALT, AST, and alkaline phosphatase. If they're more than 3-4 times normal and it's new, you send those along because something's happening. In order to help us determine what that is, you know, the CBC, INR, and bilirubin tells us what their synthetic function is. Is the liver working or not? Usually you got a pretty good idea. The most common symptom in acute hepatitis of any sort is loss of appetite and an aversion to cigarettes. Now, that's for me anytime, not the loss of appetite part, but the not liking cigarettes. But patients will tell you, I have no appetite. It's because the livers are inflamed and they want no nutrition. So that's a really good indicator. And that's what we use in clinic to decide, or in the hospital when I can send somebody home. When they tell me they're hungry, they're going home. Ruling out acute viral stuff, 85% of hepatitis A is found in your own community, not when you go to Mexico. And I'm not going to pick on any restaurants in town, but this is where people get it. You know, there are outbreaks in primary care, in pediatric centers, you're going to see. Hepatitis B, we really don't see much except in the IV drug use population. The autoimmune workup I usually expect from most folks, ANA, F-actin, smooth muscle antibodies. I only check the AMA if they're cholestatic, and usually 9 out of 10 are women in their 40s and 50s. Iron studies, ferritin, alpha-1 antitrypsin, you really don't need to be checking those. It's really the first ones, and then send them along if things are higher. And then please get an ultrasound because that'll tell you what the liver looks like if they're cirrhotic. And that's basically it for that. Next one, next slide, please. If I'm going too fast, too slow, please interrupt me. This is kind of what you're going to be seeing more in your clinic. You got patients, you've been watching them, they kind of go up and down. Usually the vast majority are going to be fatty liver, but usually follow them for at least 6 to 12 months if they're low, and just keep trying to see if there's something you can pinpoint as to why that's happening. If you're uncomfortable, your patients are uncomfortable, and you want us to see these patients, glad to. E-consult has become a tremendous tool. I'm the one who does almost every one of them, and I love doing these because we can have a dialogue and say, this is what it looks like, this is what I think, let's try that. Before we clog up the system, so to speak, it gives you a great ability to really give boutique medicine to your patient, save them time, save them, you know, the hassle of coming here, and actually reassure them. If I think, and there's something of concern, then I'll move them along. If they're sicker, you just send the referral through to general hepatology, and I'll show you what we've been working with the primary care with Mark Burley, and really try to simplify things for you, and that's coming with the enhanced referrals. Just to let you know, we have an urgent hepatology clinic. I've got 2 APPs who are spectacular, who will see somebody within a week. So if you're really worried, there's an urgent hepatology APP who will see them. If you have liver tumors, we actually now have a liver tumor clinic, which is a surgeon and hepatologist one-stop shopping. And any of the hepatologists, if you want to direct them, I love doing fatty liver. I love doing autoimmune. Dr. Larry loves doing PSC. So once you get to know us a little bit better, feel free. And we are trying to set up a FibroScan referral, and we have this. So if you just want a FibroScan and just find out what the patient's, you know, is there fibrosis, is there fat, the patient becomes their own control, we can facilitate that with you through Sawgrass. So they don't have to pay for parking. They come in, they get the FibroScan fairly quickly. It's done by our APPs, and they don't have to see us or have a full consult for that. Any questions on any of that before we move on? Too fast, too slow? Okay.
Mark,
Steve?
Mark, this is Steve Judge. I can't speak for everyone, but I would just tell you that from my end, that e-consult service is, it's a game changer. I agree, and I thank you for your willingness to use it.
Please go to the next slide. We've really used that as our template for saying, how do we get our patients in better? And that e-consult has been better than any sort of referral form I've had before. I usually get, please see liver. And I go through 38 pages of trying to figure out what it is. And then you go, what's taking so long for you to refer go through the referral? It's because I don't read that fast. And we get lots of them. So this really helps us give you, Mark, this is the information you need. And then I can get you a referral like this. And especially with an e-consult, I think we're going to be moving more and more to that. This is the FibroScan machine developed by the French. I had the rare pleasure of doing a lot of the research when I was still in Canada, designed to test cheese. I kid you not. So you can just click through these, please, Renee. But it really will give you.
Yeah. Question in the chat, Mark, from Dr. Gleason, asking about how does one order the FibroScan? Is there an order for that alone?
Not yet. That's coming. And that's one of the forums I wanted to have with you, because I really want us to actually get this machine into and work this with the primary care network and have almost like primary care metabolic syndrome clinics with you folks, because you're seeing the patients. I've got nurse practitioners who really want to pilot this, and my machine's portable. So this is something I want to move forward. The FibroScan, this is something with the enhanced referral that we're trying to set up with the FibroScan only, just so that you have that access. Patients come in. It takes a minute. So you put this thing on somebody's ribs, it fires 10 pulses through, and it measures 4 centimeters by 1 centimeter by 1 centimeter. So something the size of your index finger, and it's as representative for better than biopsy for no disease or bad disease. In the middle, it really doesn't work quite as well, but it'll tell you they have a problem or they don't. Next slide, please.
And Mark, one other question,
Please.
from Dr. Krishnan. At what stage do you order the FibroScan?
So when you do an ultrasound and something doesn't look right, they have ongoing liver tests, and you've got a 68-year-old diabetic with a hemoglobin A1C of 11. You have steatosis. You want to know, is this a problem or not? And the FibroScan will tell you, do they have fibrosis or not? And that's how we really want to stratify who I need to see. So if there's, a FibroScan saying stage 1 fibrosis, I don't need to see them. We would recommend redoing that FibroScan in 2 years, and they're their own control. So again, this is something I want to roll out with you folks. I'm trying to do it with Mark Burliant and the group here, and just saying, here are the FibroScan and fatty liver parameters. This is how we're going to do it as a community, so you have access to that as well. So I'm getting a little ahead of myself, to be honest, but I need your help to do this and operationalize it. So if somebody's sicker, the question is, how do we identify those? If they have portal hypertension, low platelets, big spleen, you get a FibroScan and it's more than 17.3 kilopascals, don't write that down. That tells you they have portal hypertension. And those are the ones that we really need to follow more closely. Why do I need to see them? If we go to the next slide, as soon as you're identified with cirrhosis, even if compensated, they're on this slippery slope going down. As soon as they decompensate, they're in trouble. So we really want to try to identify those. But once I have somebody and I've got them with compensated cirrhosis, we form a partnership with you to take care of those patients. Because really most of it's just taking care of their metabolic syndrome and a lot of other stuff that's going on. They've got autoimmune hepatitis, or that, I'll take care of that. But really, excellent medical internal medicine care is what they need the most of, because that's what gets them. Next slide, please. So what do we follow? You follow a bilirubin, INR, albumin, alpha fetoprotein every 6 months, because what happens is they've got a basically 3 to 5% chance of running into trouble every year. They develop ascites. They get goofier. Hepatic encephalopathy, the best indicator for that is not that they're in a coma, not that when the phone rings, they answer the TV remote. It's that they'll tell you, I can't sleep anymore. I go to bed, I'm walking around all night, and then I'm sleeping all day. So sleep-wake reversal is by far the most sensitive indicator of encephalopathy. But then they'll tell you, I used to lift weights, I'm losing all my muscle, and then you'll see their sodium drop and that sort of thing. But the biggest thing in clinic is you just look at them, they're getting old fast in front of you. Once they've developed that, we need ultrasounds every 6 months. I can order them and do that sort of thing, but if patients are housed in their primary care area and we work in partnership with you doing that, it makes it a whole lot easier for the patient. They have a 3 to 4% chance of developing HCC each year. If it's under 3 centimeters, I can usually take care of that with a radiofrequency ablation without doing anything else as soon as we do case finding. Once they develop a cancer, they don't go from nothing to huge in 6 months. It usually takes a fair bit of time. So we do have that window of screening. Everybody needs to be vaccinated for hepatitis B, hepatitis A, because their chance of dying with acute hep A, if you're cirrhotic, is 50%, and that's preventable. So I need your help with that. And obviously I'm trying to really hit people on the head and say, it's okay to give them Tylenol. You give them Advil, they go into renal failure, get a GI bleed, and that compounds my evenings. So I don't really like coming in to scope that. So please don't do that. They will be getting EGDs every 2 years. I'll be arranging this, and I've got a template which really says what we do and what we would ask you to do in the referral letters coming back to you folks, just to make sure it's very, very clear who does what. Next slide, please. This just shows that, we watch MELD score, because as soon as your MELD score is 14, basically, or higher, there's a tremendous survival benefit with transplant. Now, this is really broad-based, but we do know that with fatty liver patients, the earlier we go, the better, because by the time they have a MELD score of 30, they're 68 with a stiff heart and renal failure, and they don't do well. If they start decompensating and I do a live donor when their MELD score is 20, they get good 10, 15 years of quality of life. So next slide, please. These are the results that we have right now. Our transplant survival is 94% for 1 year, 80% at 5 years, 60% at 10 years. And when you get to the 10 years, your age-matched control survival is the exact same. Live donor is the really thing that we're stressing most because we don't have enough organs. 50% of our patients that have live donor transplant and our survival, and that's 100%, just so you know. 50% are back to work at 6 months. So you're taking care of the family and the patient. And again, this is not an advertisement for transplant. This is just saying we have these opportunities, but I need you to work with me, because the reason they do so well is they run into trouble with metabolic syndrome. And again, that's all in your sweet spot. Next slide, please. So again, when do I want to see the patients? If they're more than 3 times normal, refer them right away. E-consult me, direct message me. We like that sort of thing. We actually do, because for every slot I have in GI and liver, I have 4 referrals. So I need your help to help stratify it. And just sending a referral and say, hey, Mark, I haven't seen the patient yet. It's like, because we're snowed. So please direct message us. If it's less than 3 times normal, as I said, let's work together and get into that. The tests, AST, ALT, alpha, CBCI, and our ability room, you can see that as well as I can. Do the imaging, and if anything's amiss, please send them on. Next, please. This is what we're working on, just as far as for outpatient referrals coming through, and we're putting this in the electronic record. So for you, it's elevated liver enzymes, NASH. You just click it and basically send it. And that's what we're trying to do. And as I mentioned, for those who have Epic and access to Epic, this is all going to be Epic based, and it's supposed to be 2 clicks. I kid you not. This is for folks who don't have access to get this in, because when we get this and it's this clear, I can get you an answer very, very quickly. So if it's elevated liver test, NASH, fatty liver, that's going to go to our nurse practitioners and they'll see them in a heartbeat. If it's liver mass, cirrhosis, that'll go to one of the hepatologists and we'll get a more thorough look. You can see I'm kind of letting us behind the curtain to what's also happening for all of the GI other subspecialties. Any questions, or you want me to move on? I'll take that as a move on. So again, what we're really trying to set up with you folks is collaborative care. Your access to get to us, we're trying to increase the pathways. The referral pathways on Epic and otherwise are going to be streamlined and easier for you to get through. And one of the things is I am so short on PSSs, OASs as everybody is. I've got 15 open slots. The more I simplify the pathway, the more one touch I can have, the fewer phone calls going back and forth to you, the more efficient we can be. So that's what we're really striving for. The urgent GI and liver clinics are available. E-consult, hammer me, please. And I actually gave you my cell phone and my email. And you guys can share this because it's okay. Next slide, please. I think I'm done. That's a picture of my 3 kids a long time ago. The little one didn't swim well. Now, next slide, I just want to go really, really quickly. Just to let you know what we've done in the last 2 years. I've gone from 13 actually to 22 faculty. We've added 1 more fellow with Bob McCann and his help, and now with the whole Department of Medicine, we will have a full presence at Highland. So you will have GI services at Highland. We're now up to 25 APPs. All I need is more clinic space, more endo space. So we're building and we're growing to meet your need. And we'll continue to do that. And I wanted to stop there. Chad, is that short enough? Fast enough?
Just made it. All right. Thank you very much, Mark. Anybody have questions? I think we ran the list in the chat room, so open questions that folks have.
Nothing.
I know Mark has to go, and we're going to try to keep on track. So,
But again, Chad, I was going to say this is really important to us. We have 6 hepatologists. I have another general one coming. So between us, we're going to have much more support bandwidth for general hepatology. We'll be concentrating at Highland and Sawgrass primarily for general hepatology, so ease of access for the patients. But I really would love your feedback as we're going along and we're trying to make things more efficient. As I said, I've been working with Wally Johnson, Mark Burley, and for kind of the URMC primary care network. But I really need your help to make sure that across the board, we're meeting the needs and we're efficient and responsive to you. And if stuff isn't going, the squeaky wheel, I need to hear, because that's the only way we can improve things.
Yeah, I really want to tell you that the e-consult business is fantastic, and getting an answer fast is always helpful. I like the idea of having a template sent back just of what we can do to facilitate things for you as well. So I think that communication is very important.
Yeah, and the little sheet I gave you is what we're doing for a lot of the outside referral folks, but really the e-consult is going to be the template for you because it really puts on all those tests there. So when I see that, I can really, it becomes a referral template for me. So here's your quick answer and here's where we're going. So it's awesome.
All right. Well, to keep things moving along, thank you, Mark, for coming. Appreciate it. And we'll forward any other inquiries to your email if folks have station questions.
And yeah, please email me. I'd love it. And I'm going to go freeze watching field hockey. Bye now.
Sure. Thank you so much for coming. All right. So our next presenter is Jason Pecos, who is an assistant professor of clinical medicine and the second greatest history of our chief of cardiology in Highland Hospital history. He is going to be talking tonight on lipid management and primary care. So I will hand it over to Jason.
Thanks, Chad, and thanks for the shout out to Tom Rocco. We all appreciate that. I'm going to try to screen share here. Let's see if this works. I really want to emphasize a couple of things from Dr. Lovesick's talk that I really enjoyed, and one being the utilization of e-record. I'm sorry, e-record consults, e-consults, in that in cardiology, I myself with Chris Montgomery and Imran Chaudhry are the 3 people that do the e-consults. And we really don't get that many of them. They're really not that laborious. And so if you have questions, please utilize that. In my predecessor's wisdom, we used to have an access line where people could call a back line at Highland to speak with a provider. Unfortunately, it became untenable in that the amount of calls that we got on a daily basis really was unable to be kept up with and answered in any sort of efficient manner. And so I think that utilization of the e-consult can certainly overtake that method of access. And if there are access issues, let me know. We can certainly do everything we can to do that. And then on top of that, whatever the 1 in 643,000 people with statin-induced hepatopathies is rather reassuring, and so don't stop the statins.
Jason, can you change your display settings just to go to presenter view?
Sorry, but is it backwards?
Nope, top left display settings. Yep, and swap presenter view.
Is that
There you
better?
go. Perfect.
Thank you. Okay, and so I'll get started here. To start with this population, I really wanted to emphasize that it's not all medications. And by the time people get to see us for treatment of lipids, these things have been addressed many times, but I think it's important that they are emphasized every time we see people, and that, right, and that we assess the risk as well as psychosocial barriers and health literacy barriers that limit access to care and appropriate care. Diet and exercise, as well as people in food deserts, whatever it may be, that limit access to healthy dietary choices. I know myself, by getting home after this, we'll be making not the healthiest dinner for the kids, and those are realities of life. Exercise and physical activity, certainly sitting in a chair for the last 8 hours, and then everyone sitting in a chair here listening to this for the next 30 minutes or so, is not what we tell our patients to do, and is not what we should all be doing, and that exercise is certainly important. Obesity, dietary lifestyle modifications, treatment of diabetes, high blood pressure, tobacco, again, all these are important things for lipid management, and in addition to medical therapy, should be addressed with patients. The patients will not address, particularly in this session, are those that are for secondary prevention. And these are the patients that typically are established with cardiologists or vascular surgeons, neurologists, and those that have established coronary disease, prior stroke, peripheral arterial disease. And that patient population, high intensity statin therapy at minimum is indicated, plus other therapies to drive that LDL as low as possible, ideally below 70 or even 55, based on whatever literature you're utilizing at the time. Again, I would welcome questions, comments, if anything comes up. I cannot see the comment box, so if anything comes in, Renee, feel free to interrupt me.
One brief thing, Jason, just to call it out, for practices that don't have e-record access, how can they do the e-consult? Is that best done by email?
I think email certainly probably be the best way to do that. My email is on the universal, and for people that don't have access to it, that certainly is an option. I think almost everyone on here either has my cell phone or text me with questions about things, and that happens all the time. These are common questions that I get all the time. I don't think I play around with golf with anyone that is not a physician that doesn't ask me about their cholesterol or heart risk. So this happens pretty commonly. Again, special considerations in patients with LDL greater than 190, which is typically associated with familial hyperlipidemia, always should be treated. Diabetes, anyone, again, ages 45 to 70 should at least be on moderate intensity statin therapy, and those associated with risk factors should probably be on high intensity statin therapy.
There is a question in the chat.
Question about e-consult for borderline ECG findings as well. Yes, so that is probably one of the most common findings we find on the e-consult is ECG questions or abnormalities. If you are sending one, I highly recommend that you scan it into either the media section or utilizing Haiku into the e-consult, because often they do not get in there very quickly, if they get in there at all. And from the primary care network, they often never get in there. So really appreciate having the EKG if you do have a question about it. And again, they can certainly be faxed to the office or emailed with questions. Generally, if someone has an ECG abnormality and they're asymptomatic, that is not an urgent finding, and they can certainly leave the office with follow-up thereafter. Those of you that use eRecord, I'm sure are familiar with the .ascvd code, which I utilize about 1,000 times a day. This is the ACC-HA version, which actually is a bit better in that the age is a little bit goes down to 20. The ASCVD risk score that's in our record, I believe, starts at 45. So if there are high-risk patients with risk factors below 45, often you have to go to the website to get the calculator to estimate the risk. So this risk score, the 10-year atherosclerotic risk, is really one of the most, I think, meaningful findings that we have in patients, other than identifying what their risk is based upon their diabetes and other risk factors. But defining what that risk is often, I think, one, puts it in perspective for the patient and also helps us to kind of guide what their treatment and therapy action should be. This is a little bit of a busy slide, but really the things to think about are those, the breakdown is patients, their risk score below 5% over 10 years, in the borderline range between 5 and 75%. And then the vast majority of patients, which is going to be the intermediate risk, the 7.5 to 20% risk over 10 years, are the patients that really are where the most questions lie. If they're really low risk, it's again, dietary and lifestyle modifications, risk factor modification. If they're very high risk, they should be treated with high intensity statin therapy and lipid lowering agents. The intermediate ones are the ones where some more thought is necessary. This again is a busy slide, but it's probably the most comprehensive slide in which you can use to go through to assess what to do with your patients. Again, the exceptions here, the elevated LDL greater than 190, diabetics with risk factors, all should be treated. Then looking at this intermediate risk patient, and these are the ones I'm sorry, I'm putting my mouse on the wrong page. That's 5% to 20% range are typically the patients that we see often for primary prevention, and that they decide that they hit 40 and they want to be healthy. A brother had or cousin had a heart attack and they want to, change their life. Something happened, some life event, and they want to come in to try to determine what they can do to be healthy. And then based upon that, looking for secondary risk enhancers, including family history, elevated LDL above 160 persistently, kidney disease, metabolic syndrome, conditions that women may have during pregnancy, including preeclampsia, premature menopause, inflammatory disorders, rheumatoid arthritis, psoriasis, HIV, are all things that certainly can lead to discussions to treat and to treat sooner. Other labs, including HSCRP, LP(a), and ApoB, I personally think are a little less helpful in that patients looking at additional labs often doesn't really help them understand what their risk is. So what I prefer to do is review any imaging that they have, including, typically someone's had a CT scan or a chest X-ray or something along the ways, looking for evidence of atherosclerosis or calcification. And if there is, that's certainly an indication that they are at higher risk. If not, then proceeding with a coronary calcium scan. And this is the ACCHA guidelines 2A recommendation for patients between 7.5 to 20% risk. And what coronary calcium is the beginning of deposition of plaque in the arteries. All right. And so we've all seen this diagram from medical school, and in the lipid-rich plaque and all the lipids and cholesterol that forms in there, the metallic proteins, all that stuff. One of the things that's in there is is calcium, and calcium is what causes the atherosclerotic, again, hardening of the arteries, and that can fairly easily be quantified. Coronary calcium scan, it's cheap. Patients, unfortunately, the one thing I will say is insurers in this area are loath to pay for anything, including coronary calcium scans. I would say about maybe 50% of ours get approved. The out-of-pocket cost is $156 at certain local imaging facilities. And at the university, I believe it's $175. It's quick, it's easy, there's no contrast. They just need to be able to lie flat. No pre-medication, no fasting, and again, very small amount of radiation, about this similar to a mammography, abdominal X-ray, or about 10 chest X-rays. So what that shows is coronary calcium, and what that shows up on as is white, bright findings on this non-contrasted CT, which should be very obvious and able to quantify. How it's quantified is in Agaston units. So it's 0 is obviously not identifiable. 1 to 99 is low. 100 to 399 is moderate, and greater than 400 is severe. Additionally, in addition to the amount of coronary calcium, you can see the distribution in the blood vessels, as well as in the report, it is described as what the risk is, or what the percentile for patients based upon sex and age. Question about insurers covering, not very well locally, and it's unfortunate, and it's been an ongoing battle amongst the many that we're having with the insurers and covering. In my quick literature search, or looking at cost, the cost of $150 is probably equivalent to that of ordering a APO little a test or apoprotein B. So the lab test of those combined is probably more than that of a coronary calcium score. And I think the coronary calcium score gives you a lot more information than an additional lab test regarding lipids. Once you have a coronary calcium score, what you can then use is a MESA score. The MESA study looked at atherosclerosis in asymptomatic patients, and the big finding is that a coronary calcium score of 0, it means that you're low risk for cardiovascular death or MI, starting at 3.5 up to 5 years. A calcium score between 100 and 300 increases the risk by about 8%, and greater than 300 by about 10%. So the threshold that we use to find that there's significant risk is that coronary calcium greater than 100, because that increases the estimated risk over 10 years, over 5 years, to 7.5% risk of MI or cardiovascular death, which is fairly significant. Very high coronary calcium scores are associated with a much higher risk over time, which is not surprising. Again, this is a study that utilized both the Framingham risk score and the coronary calcium score, demonstrating that combination of both is indicative of higher risk. This is, again, not surprising stuff, but it is validated. Now, who would benefit? In my opinion, it's those intermediate risk patients between 5.5%, 7.5% to 20%. Men over the age of 35 and women over the age of 45, including and those that have risk factors, including family history, hypertension, history of smoking, obesity, diabetes, and hyperlipidemia. This is the vast majority of our practices, and that we see patients that are in the intermediate risk and have some of these risk factors. I really find that the coronary calcium score is very helpful in finding their risk, as well as demonstrating to them what their risk is. Who it's not helpful for typically is symptomatic patients, and that alone checking a coronary calcium score does not rule out acute coronary syndrome. For those patients at the ends of the spectrum, either very low or very high risk, and that treatment is unlikely to be beneficial for either of those. Patients with known coronary disease, it's not helpful because it's going to be elevated, and typically there's not evidence for serial assessment of coronary artery or coronary calcium score over time, with those of the exception being that with a score of 0, maybe checking it after 5 years to see if there's been progression with lifestyle modification.
Hey, Jason, can I ask you a quick question?
Absolutely.
So this scenario, you can make fun of me, but so a guy with you do the AHA, ACA calculator, and his risk is 25%, okay?
Yep.
And this guy is not going to take a statin no matter what.
Yep.
So I know you say in your slide there, probably not a real role for doing this, but I have in that person on occasion done a coronary artery calcium scan.
Yep.
Now, in the same way that it can be used as a risk multiplier, what if that person comes back with an Agatston score of 0 or less than 99, which honestly I have had before? I mean, does one trump the other? Do I then say, well, your risk is probably not 20% or 25%? So, I mean, it's backfired on me in situations where patients say, well, I don't have a lick of calcium. Why would I take a statin? So I guess, what's your opinion about that?
Well, I think that what you would identify as someone that has low risk, right? We don't know enough about atherosclerotic genetics to know who is at high risk and who's at low risk. And I do think though, if someone that you think is at high risk doesn't have evidence of coronary calcium at that point, and they're not going to take a statin, I think that continued aggressive lifestyle modification, exercise, diet is certainly very reasonable with serial assessment of that coronary calcium in 5 years to see if there's progression to potentially treat. I really have found that the coronary calcium score is very beneficial. Again, if it's 0 or if it's high, identifying risk and helping patients understand what is in their coronary arteries is what we expect to see there one way or the other, and that helps them to either comply with treatment or makes me a little more comfortable not treating for some time and then following over time.
That's helpful. Thank you.
Dr. Legapan asked about lung cancer screening. He beat me to the slide. One of the things I do whenever I see someone that comes into the office is I always go through their radiology imaging, see if there's a CT scan there of some reason, or if there is frequently get consults for patients that have identified as heavy coronary calcium on lung cancer screening tests. Unfortunately, they're not quantified. It's usually a small, medium, large, or extensive. Again, the risk factors that cause lung cancer cause heart disease, and if there is extensive coronary calcification on the CT scan for lung cancer screening, I typically will treat. Same thing as in oncology patients, they get tons of scans, as you all know, and they can identify calcification on those, and on mammography if there's arterial calcifications as well. I know Chad's getting me to get started. And so treatment is, again, lifestyle modification for everybody, likely antiplatelet therapy with aspirin, as these are higher risk patients, and lipid lowering predominantly with statins. If I knew how to spell, it'd be a little bit better. Or other alternative agents. Again, I think the most important thing to realize though is an elevated coronary artery calcium score does not indicate obstructive coronary disease. They're at high risk over time, but it does not mean that they're at immediate risk and that they should have their risk factors treated, but they do not need a stat cardiology consult for a coronary calcium score of 800 because they're going to die tomorrow, which is actually, I saw someone with that same story today. That's not the case. If someone's without symptoms and they have elevated risk, that means we should treat their risk over time. And I do find it's very, very helpful for patients to visualize what's happening in their body and why we want to be aggressive in treating the risk factors. I'll be very brief and show 2 examples of patients I've actually seen. These are the typical 45-year-old males who have had some vague chest pain, want to be seen to assess their risk over time. First guy has no family history. He has average plus alcohol use, fairly active, but moderate exercise. Diet is typical. Blood pressure is normal, non-diabetic, normal kidney function. He had an echo for his atypical chest pain in an outside facility. It was normal. His ECG was normal. His LDLs 160s, 168. HDL and triglycerides are reasonable. His 10-year risk is about 5%. Another patient I saw who has a very strong family history, his father was my patient and died of coronary disease in his 50s. He eats a very healthy diet. He has a desk job, but exercises very regularly. His blood pressure is controlled. He is not diabetic. He has normal kidneys, a normal ECG, and his LDL is 176. To help further risk stratify those patients, they got coronary calcium scores. The first patient who had no family history and not the healthiest lifestyle had a total coronary calcium score of 104. That's above the 100 threshold that we think is significant and increased risk over time. For a 45-year-old, that puts him in the 99th percentile, which was rather high risk. His calcium was distributed throughout all the blood vessels, and he was started on aggressive lipid lowering with an LDL target of 70. The second patient, who had a very, very strong family history, had a coronary calcium score of 0. He continued on dietary and lifestyle modification with a prominent plant-based diet and exercise regularly, and with plans to repeat that over time. Questions? Did I finish in time, Chad?
You finished just in time.
Perfect.
Didn't have to pull out the hook. Any questions for Jason? All right. Thank you, Jason. You can stop sharing,
Hi, this is Shaida. I have a question.
please.
So when we see CT scans or mammograms indicating moderate to heavy calcification of the coronary arteries, and the lipid panel doesn't, the risk is not high enough, just seeing that moderate to high intensity, is that enough to put a patient on statin?
Short answer, yes. I think that if you see evidence of calcification, again, arterial calcification, you're seeing atherosclerosis. So often we'll see it if someone has abdominal pain, gets a CT scan for looking at their gallbladder, or a chest X-ray or a CT scan looking for P or something while they're in the hospitalized for some other reason, looking at those scans to see that there's evidence of atherosclerosis at that point. I would argue that treatment to stop the disease process is warranted prior, despite what their risk is, that the LDL less than 70 will lower the risk of cardiovascular disease over time.
Thank you.
And one more question about an LDL less than 55. Some of the societies are striving for lower LDL score. There's some evidence that I think there's evidence that's pretty strong that the lower the LDL, the better. Dr. Brunwald, who's the godfather of cardiology, said, one of his talks he said is that, the one thing I know, there's two things I know in life, and one of them is that the LDL can never be too low. So lowering that LDL to target is certainly the goal. The lower the better, and I think that probably in the next few years that will find that very high risk patients, the lower LDL target will be stressed going forward.
Perfect. Thank you much, Jason.
Thank you.
All right. Our final speaker this evening is Dr. Michael Need, who, aside from having been my chief resident 100 years ago, is probably better known for being associate professor of medicine in the Division of Pulmonary and Critical Care Medicine at the U of R, and is the director of the Pulmonary Nodule Clinic at URMC. And tonight he's going to be talking about the aggravating finding of pulmonary nodules on routine imaging and what to do about them. So I will hand it over to Mike. Thanks for being here.
Can everybody hear me?
Yeah.
Excellent. All right, so I can talk about what to do with the nodules you find when you do your calcium score CT. So I'm Michael Need, for people that don't know me, and I'm going to talk about nodules in a nutshell. So I'm going to try to go through everything you need, and I apologize about the background there. I'm going to try to go through everything you need to know about nodules in 15 minutes, thereabouts, and also take questions. So bear with me. And it seems like people have been chiming in with questions. So feel free to chime in with questions as we go, although that may make me run over a bit. I do have one disclosure. I got a couple $100 from Intuitive Surgical for providing some system feedback on a robot. It's not much, but it is a disclosure. So again, in the next 15 minutes, I'm going to tell you what you need to know about nodules. Just a very brief overview. This is a pretty smart group, so you know all this stuff already probably. I'll talk about nodule and patient risk factors for cancer. I'll talk about when you should use lung rads versus the Fleischner Society guidelines and thinking about nodules. I'll tell you a little bit about nodule calculators. We'll talk about some nodule management guidelines. And again, I'll take questions at the end or as we go along here. So nodules 101, a nodule is basically a roundish spot in the lung. It doesn't need to be round. It can be oval, elliptical, it can look like a star, but it's a spot in someone's lung less than 3 centimeters. So if you look at your own scans, a nodule that's 2.5 centimeters is really big, but it's still a nodule. Once you get above 3 centimeters, you start talking about a lung mass. And some of that is semantics. It doesn't matter a whole lot in how I manage a 2.5 versus a 3 centimeter nodule. But those are the definitions. Approximately a third of all chest CTs that are done are going to pop up with a nodule. So in the United States, that translates into about 1.6 million nodules found on scans per year, which is a tremendous number of nodules. And thankfully, not all of those are cancer. In fact, the vast majority are not. So about 95% of all these nodules we find are granulomas or intraparenchymal lymph nodes. So if you ever see a small circular nodule right up against the pleural surface or close to it, it's probably a little lymph node. We're still going to be stuck following it most likely, but you can at least give some reassurance to your patients. So the patients you need to worry about are the ones that have bigger nodules, and then patients as they're getting older, and then certainly those with risk factors. And we'll talk about those things in just a minute here. We categorize pulmonary nodules 3 different ways: solid, ground glass, and semi-solid. And the risk for those and how you manage those differs. So I'm going to go through those in a little bit of detail here. So this is a ground glass nodule. It's a little roughly 1 centimeter fuzzy spot in somebody's lung. It looks fairly innocuous, and for the most part it is. It's got some vascular markings around it. Those aren't semi-solid components in it, but that's a ground glass nodule. And when you biopsy one of these or take it out, this is what you actually see. So instead of the nice thin sort of alveoli that we can all remember from medical school, we've got these thickened alveolar walls. We've got all these atypical pneumocytes lining the alveoli, and this is what gives your ground glass nodule in patients that we need to worry about. Certainly, you can have ground glass nodules that are from scar, and that's why not all ground glass nodules are necessarily bad. However, if you have a ground glass nodule that persists at over 1 centimeter for 3 months or more, that's got a high risk of malignancy. It might not be a cancer you need to worry about per se, depending on the age of the patient and whether you see it evolving over time. But the odds that that nodule, that ground glass nodule, is a cancer is fairly high. PET scans for these nodules are of limited utility. So if you're in the habit of hearing about a nodule that's 15 millimeters and knee-jerk reaction is order a PET scan, don't do it for these because they're not very helpful. And patients only get so many PET scans from insurance companies over their lifetime. So don't burn it on your ground glass nodules. Trying to get my screen to move forward. Next are the semi-solid nodules. And these we manage based on the solid component. And if the solid component takes up more than 25% of your lesion, that's a high cancer risk nodule. And if it's growing, that's also very concerning. So here you can see a nice ground glass nodule with a solid component. That's actually a blood vessel right there, but that's the solid component of that semi-solid nodule. And as you can see over time, it grows. That's a very concerning lesion. This deserves a resection or a biopsy. I'm not going to spend a lot of time talking about how we decide which, unless it comes up in questions, but this is one I would biopsy because to resect that is going to cost somebody a lobe. If it's over near the edge, you can do a little wedge resection, get the answer, but here that's going to cost somebody a lobe to figure out what that is. So this is somebody I would biopsy to figure out what that is. And then what most people think about when they think about pulmonary nodules are the solid nodules. And here are 2 different examples. So this is a very well demarcated nodule, smooth borders, rounded. That could be a large granuloma. That could be a carcinoid. That could be a metastatic lesion from someplace else. There's all sorts of possibilities for that. This lesion in somebody without infectious symptoms is cancer till proven otherwise, in my mind. It's spiculated. It's embedded in a sea of emphysema. This is a problem nodule. And this is also one that doesn't warrant a CT-guided biopsy because of all that emphysema. This is one that warrants a bronchoscopic biopsy. So when we're talking about solid nodules, we sort of risk stratify them based on size because we know that the odds that a nodule is cancerous goes up with size. I mean, that's kind of intuitive. I don't think you need to go to med school probably even to figure that part out. But if a nodule is only 3 millimeters or less, most radiologists won't even report it. The odds that that nodule is going to be cancer is 0.2%. Contrast that with nodules over 2 centimeters, depending on the appearance. In this series, at least, those nodules had a 50% chance of being cancerous. So again, increasing size, increasing risk of cancer. There's other nodule factors that we take a look at when we're talking about risk stratifying them. So on that one solid nodule, I talked about those smooth edges suggesting more likely to be benign, whereas the cancerous nodules, like the one that was on the right-hand side of your screen with the spiculations, those are hallmarks of a cancerous nodule. Calcification patterns as well. So if you look at your own scans, the ones that are laminated, popcorn shaped, or even a nice center calcification, those are benign. the ones that are cancerous, heavy centric, stippled calcification, sort of punctate scattered through it. So those are ones I would worry about. And similarly, the upper lobe nodules are more likely to be cancer than lower lobes. So in addition to nodule characteristics, when you're thinking about nodules and what you're going to do with them, you need to start thinking about your patient, the person that's sitting in front of you. So these are risk factors that we take into account when we're talking to patients. Do they smoke? What kind of a background do they have? Certainly if they're a pipe fitter, which we're seeing fewer and fewer of, and they smoke, their odds of that nodule being cancer is about 60-fold that if they didn't have the asbestos and the tobacco. If they've got a history of malignancy that's recent, there's a 10 to 30% chance that patient's nodule could be metastatic. If they've got COPD, like that patient on the right-hand side of that screen that I showed you previously, that increases the risk. Family history as well, and then age increases the risk of cancer as well. So we've got an incidental pulmonary nodule you just discovered. You've thought about the nodule characteristics. You've thought about your patient characteristics. What do you do with this? You go to your Fleishner Society table, and this is something I pull up every day in clinic. If you just Google Fleishner Society 2017, it's going to pull up the table here. Just go to images, and literally with almost every patient in clinic, I'm showing them this table so that they understand the rationale behind what we're doing. On this, you're going to see the size of the nodule. You're going to see it broken down by solid, part solid, and ground glass, whether it's a solitary nodule or whether there's multiple nodules. And then they want you to risk stratify the patient. So you've got your nodule characteristics, and then you've got the risk factors that your patient carries with them. I started with this part right here, mainly because nodules less than 6 millimeters, we really are told not to worry too much about, but there's this little clause here that says, if suspicious morphology or upper lobe location, consider a 12-month follow-up. Honestly, if somebody's over the age of 35 and they get to me and they've got a nodule that's 5 millimeters, odds are I'm going to do a scan. I'm going to talk to them about the risks and the benefits. But if they've gotten to me, if someone's referred them to me and they're that concerned for a 5 millimeter nodule, I'm going to do a 12-month interval scan. Even the high-risk patient doesn't necessarily need a scan here. So you need to have the discussion with the patient about risks and benefits. If you do a scan for follow-up and you find something else, what are you going to do about it, right? What's the radiation risk, et cetera? I skipped over the 6 and 7 millimeters. They're all on the table. I went right to the greater than 8 millimeter nodules because this is where I think things get interesting from the primary care standpoint. And you need to decide for yourselves whether this is somebody you want to follow or if you want to send off for consultation. So when we talk about greater than 8 millimeters, the first thing I want to point out is that that's the average dimension. You take the length, the width, you add them together, divide by 2, and that's your average dimension. And that's what all the criteria that we're talking about are based on. So here, things get a little bit dicey. For your low risk and your high risk patients, they get treated the same way with a solitary dominant nodule that's greater than 8 millimeters. And here you're going to see that you've got this mix where they say, well, you could do either a CT in 3 months, you could do a biopsy, or you could do a PET scan. But if your PET scan does not or doesn't necessarily exclude cancer, you got to figure out what you're going to do. And oh, by the way, if it's close to the diaphragm, your PET scan may not matter anyway, right? So there's a whole bunch of factors that go into that sentence that you need to be willing to think about and discuss with your patient. So that's why as a primary care doc, it's really those nodules above 8 millimeters where I would think about referring somebody. It's not that you guys can't figure this stuff out. It's not rocket science, but there's a lot of different variables. And God bless you for everything you have to manage on your outpatients, but this is something we're more than happy to take over for you. For the part solid nodules, again, if they persist and you've got a solid component greater than 6 millimeters, that's highly suspicious. I'd think about doing a biopsy or having us take a look at those as well. And then for those ground glass nodules, if they're growing, resect them if they're close to the edge, do a biopsy if they're not, just so you can figure out what it is that you're dealing with. So that's the Fleishner Society guidelines. They apply to almost any incidental nodule you find, unless the patient's less than 35, because patients less than 35 have an extremely low likelihood of having cancer. So in that patient, you should be thinking infection, infection, infection. Similarly, with your immunosuppressed patients, they're more likely to be infected than they are to have cancer. And And then the flip side is that your patients who have a recent history of malignancy are more likely to have cancer than not. So these are ones that you may treat differently as well. I said that I was going to discuss lung rads briefly. Here it goes. Lung rads doesn't apply to incidentally discovered nodules. Lung rads applies to patients who have a lung cancer screening CT scan. So any patient who has a lung cancer screening CT scan should have a report that comes out that gives them a lung rads designation. 1, 2, 3, 4A, 4B, 4X, etc. And it should be on the report. If it's not, you need to talk to your radiologist because they're not doing their job. The lung rads 4s are confusing because even there, you get that same a la carte that I showed you with the nodules greater than 8 millimeters. You can do a CT, you can do a biopsy, you can do a PET. And we've seen patients where the primary care doctor, no offense to anybody, has done all three. They've ordered a contrasted CT, a PET, and they've arranged a biopsy. So to try to figure out which one is right for patients, we've actually convened a lung rads 4 review committee where we have a thoracic surgeon, a pulmonologist, and a thoracic radiologist looking at any lung rads 4 done within the URMC network. So that's all the way down to, it includes places done at Noise, for instance, any place that's being scanned on a UR medicine scanner, if you will, we're looking at and we're commenting on it and reaching out to the person that ordered that scan to provide some additional guidance so that you and your patients aren't struggling with what the right next step is. So I talked a little bit about nodules over 8 millimeters already. This is where you're going to break out your nodule calculator. Jason showed some nice cardiology calculators. There's some great ones for pulmonary as well that you can pull up on your phone as an app. They're available and up to date as well. But the nodule calculator you want to use is going to be most accurate if you apply it to the population to which it was validated. And I think that this gets lost. I think most of us sort of reach out for the nodule calculator that's most convenient or we're most comfortable with. But I would encourage you to use the Brock University calculator for any nodule found with lung cancer screening. Realistically, these are ones that we're going to be giving you guidance on anyway. And then the Mayo Clinic calculator is great for incidentally discovered nodules because that's what these calculators were validated for. There's other ones out there as well, but these are probably the two that have been sort of studied the most and are tried and true. If you're used to looking at your own scans and this is something you do, you can actually get really good at figuring out which nodules to worry about on your own without using a calculator. So I don't know what happened to reviewer 3, but here we have reviewer 1, who's a radiologist, reviewer 2, who is a pulmonologist, and reviewer 4, who is a surgeon. And we're comparing that to actually, this is the Mayo model, which is a logistic model. And you can see the area under the curve for all 4 of those is pretty darn close. So if this is something you do every day, you get pretty good at it without using a calculator. So where does this come into play? I think it comes into play when you want to apply this to published guidelines on how to manage your nodule between 8 and 30 millimeters. So this is from the American College of Chest Physicians. It was published in 2013. There's a new version that's probably going to come out in the next year or so that it isn't going to change a whole lot, is my understanding. But you're going to start off with your nodule, again, in that range, that 8 to 30 millimeters. And the first question you ask is, can I resect them or can't I? If they're a high risk for going to surgery, then you need to think about a non-surgical biopsy or just following them. And then you go down the decision tree. But it's right here where you're going to break out those decision calculators and you're going to assess the clinical probability of cancer and put them into 3 buckets. And the middle bucket is huge, right? 5 to 65%. The very low is tiny, less than 5%, right? So this is my 36-year-old, I never smoked, but by the way, I got a nodule patient, right? Those patients should almost always get CT surveillance. The vast majority of patients are going to end up getting a PET scan. 5% up to 100%, they're going to end up with a PET. Who I do a biopsy on and who I'd recommend you do a biopsy on depends on the clinical situation, and we can talk about that later. But this is really the decision trees that we use in clinic to figure out what to do with patients with nodules in that range. We got a couple of questions that are popping up in the chat box. Let's see. I think the radiology team should be part of such decisions. Automatic with result. PCP should have assist. Doesn't radiology do this often? I'm not sure what you're referring to there. Are you referring to the lung rads and what should happen with the patient? If it's the lung rads, there's too many decisions. So follow-up plan. So yeah, so radiology does do this, but I would argue that the radiologist might not necessarily know whether or not something is resectable. They may not know the best plan for biopsying something. So radiology is pretty good at it, but they may not know the nuances. So that's why that lung rads 4 committee that we have for lung cancer screening, at least, gets input from those 3 different groups. For the incidentally discovered nodules, the issue you run into is you can have a general radiologist reading a scan. And God bless them, they have to read head MRIs and foot fractures and everything else, but they're also reading your chest CTs potentially. So that person might not be as versed as to the guidelines and what the best next approach would be. So that's something to consider as you're getting a recommendation. And then weren't 20 millimeter nodules. Yeah, so 20 millimeter nodules once were small nodules. On chest x-rays, they were still considered small, but now a 20 millimeter nodule is actually a relatively scary nodule, depending on what it looks like. And then low dose CT criteria is so wide. Absolutely. So the point there is that annual screening becomes a mockery if we don't make them stop smoking. I think you need to have that discussion every time you talk to your patient about whether they want to continue with their screening CTs. The most cost-effective thing that we can do is to push smoking cessation. It's got to be a discussion every time you talk to a patient about their screening CT. And there's all sorts of great references out there on how to do that. And I can't speak to other centers. I know URMC has at least 4 or 5 different programs to help with smoking cessation if it's something that is just taking too much time in the clinic. But hands down, I agree. It's something that we need to stress. So when to refer, I think a nodule over 8 millimeters, especially with concerning features, I would consider having somebody take a look at it. Growing nodules, I don't care what size. I did a biopsy on Monday on a patient whose nodule had grown from 2 to 4 to 6, and we biopsied it and it was cancer. And this is somebody who's not going to be resectable, unfortunately. But because of the way that nodule was growing, they warranted a biopsy. If you're considering doing a PET or a biopsy and you're debating about what kind of PET is the right kind of PET, do I need a PET MR? Do I need a PET dotatate? What's a standard PET? This is something you may want to hand off to somebody else. Similarly, if you're not sure about the pros and cons of a CT guided biopsy versus robotic bronch versus a wedge resection, that's somebody else you may want to refer along. And then the last thing I would comment about working the patient up is lymph nodes can't be overlooked. So in a lot of patients, especially with a nodule in the inner 2/3 of the lung, if that nodule proves to be cancer, they're going to need their lymph node staged. And if they need their lymph node staged, should we do it all in one fell swoop in one procedure rather than 2 different procedures? If you're anxious or the patient is anxious, I'd refer them along just so we can have the discussions. I've got more time in my clinic to talk to a patient with a nodule than you probably do. You know the patient better, but I might have more time to go through all the details. And I know that Jason was talking about e-consults. We also don't get a ton of e-consults on nodules. We're happy to do them. Consider using those if you're in network. If you're out of network, it gets more challenging. Certainly you can fax things to us. You can call us. We're more than or email me. And we're more than happy to try to weigh in and help out. All right. So I think I blew through that. I have no idea what time it is, but hopefully I didn't go over too much.
You were pretty much right on time, my friends. That's pretty good.
Excellent.
And you've covered everything in the chat, so you get extra stars for your performance tonight. Well done.
All right. Do people have other questions?
No, I do want to plug your comment about e-consults or, emailing you. I think the most important thing is to ask questions from the internal medicine standpoint. And so having that outlet for someone to say, hey, can you look at the scan and tell me what I should do, I think is extremely helpful. So thank you for that, Michael.
Yeah, at any time. And I'm more than happy to help. As people know, our thoracic surgery group is also very active as well. I thought I might get questions about who to send to thoracic, who to send to pulmonary. You know, we're like an overlapping Venn diagram. We do have a lot of overlap in what we do. I think personally, I think the perfect patient to see a thoracic surgeon is somebody with a concerning peripheral lung nodule that needs a wedge resection. Get rid of it. I will say that probably my number one referral for robotic bronchoscopies at this point is actually thoracic surgery. So they're seeing patients that they need biopsied because they're either they can't be resected or they want a biopsy before resection. So.
Any final questions for Dr. Need? All right, thank you, Mike. Appreciate you coming.
Sure thing. Thanks for having me.
And really want to thank all the speakers. Great presentations. Everybody stayed on time, which is magical, especially at night. And thanks to all of you for coming and making time for this. I know it's hard to carve out into your schedule, but hopefully you found that valuable and useful. We're going to try to be very sci-fi. And so for your post CME survey, if you pull out your camera phone and add it at that very Van Gogh-y looking picture there of the QR code, it will take you directly to the online survey if you so choose. Otherwise, Renee has put into the chat the link to the Survey Monkey that you can complete the survey there as well to do your post-course survey. So thank you very much for doing that. If you haven't already, if you could make sure that you put your name and practice name in the chat, just so we have that for attendance purposes as well, that will be helpful. We will be sending out the slides for everyone to review if there's pieces that you want to follow up on or have reference to. And likewise, for those who may have interest in the maternal child slides, as we promised before, we'll be sending those out, but you also will be able to access the recording from both the adult and the maternal child sections for later review if you so choose. Also in those slides, the information for how to reach Bob Adams for those who want to reach out to schedule a pharmacy follow-up meeting, you can do that as well. And as always, you can email Renee or myself, and we will be happy to triage you to the appropriate location based upon your questions and needs. So thank you to everyone for coming tonight. Hope you found this useful, and we will see you back at our next meeting, which will likely be the next COVID call. So thanks everybody for coming, and have a wonderful evening. Take care.
I'm gonna jump over to the maternal child one. Sheree, thank you for everything. Have a great night.
No problem. Do you want me to type up the names and send them to you or Jana, or we'll cover it whenever you want?
Yeah, just send it to me. That's good.
Gotcha.
Jane's on vacation, so we'll leave it.
Oh, yeah, that's right. All right.
All right.
Have a good night.
You too. Good night.
Thank you. Bye.